Intimacy carries an implicit pressure to perform, which can quickly mutate into a deep psychological dread. The fear of an accelerated, uncontrollable physical response feels like a tightly wound spring snapping loose long before it should. For 30 to 40% of the global male population, this loss of control is a statistical reality. It is the single most common male sexual dysfunction. In the mid-20th century, researchers like William Masters and Virginia Johnson began compiling observable data, gradually shifting the clinical perspective of sexual dysfunction away from a moral failing and toward empirical science. Clinical data identifies this condition as a standard neurological reflex arc, one that is simply triggering sooner than intended. By stripping away the social stigma and analyzing this physical process as a biological workflow, we can isolate the specific variables causing the acceleration and recalibrate the timing of the entire system. The biological sequence begins when sensory nerves register sexual stimulation, processing it as incoming data and transmitting it straight up the spinal cord to the brain. As we can see in this flowchart, the brain acts as the main governor of the system. It relies on a neurotransmitter called serotonin, which operates as a chemical delay timer to regulate the speed of the downward signal back to the body. The signal hits the central relay station. In this illustration, the spinal ejaculatory generator is at the L1 and L2 lumbar vertebrae. This triggers emission, mixing reproductive fluids, and expulsion, driving contractions through the pelvic floor nerve networks shown at the spine's base. A normal climax is a highly coordinated sequence of these exact events. Early climax is a mechanical, premature firing of this specific nerve arc. If the sequence is a predictable reflex, the problem arises when the brain's delay timer unexpectedly drops to zero. Several biological variables can disrupt the chemical baseline. A naturally low level of serotonin will physically shorten the reflex window. Localized factors, like an overactive thyroid or an inflamed prostate, can also accelerate the response. Psychological variables are equally disruptive. High levels of stress or performance anxiety trigger the autonomic nervous system. This initiates a fight-or-flight response, rushing the physical reflex to completion. Men with erectile dysfunction often struggle to maintain an erection, physically overcompensating by rushing the sexual act, developing an acquired form of this timing error. Biological and psychological factors quickly combine into a runaway feedback loop. An initial physical failure creates intense anxiety, and that resulting anxiety virtually guarantees the system will fail again the next time. Modern treatment targets the brain, spine, and nerves through a multimodal approach: pharmacological, behavioral, and psychological interventions. Focusing on the pharmacological node, SSRI medications artificially raise the brain's serotonin levels to a stable, higher threshold, physically lengthening the biological delay timer. Another localized hardware intervention involves applying topical anesthetics, like lidocaine, directly to the skin. This physically dampens the intensity of the sensory data traveling up from the peripheral nerves to the spine. Behavioral therapies act as software patches. Techniques like the start-stop and the squeeze methods require pausing sexual activity right before the reflex fires. This manually interrupts the sequence to physically build tolerance over time. Targeted physical therapy, specifically Kegel exercises, conditions the pelvic floor muscles. This provides manual override control over the final expulsion phase of the reflex. Chemical and physical interventions effectively treat the immediate symptoms and reset the body's baseline. However, they do not resolve the underlying mental loop. Cognitive counseling and sex therapy work to break the cycle of performance anxiety. By resetting the brain's expectation baseline, patients learn to process intimacy without triggering a fight-or-flight response. This data visualization illustrates the overall effectiveness of these interventions. When patients combine behavioral, pharmacological, and psychological therapies, clinical success rates jump significantly, showing improvement in up to 85% of cases. With the biological and psychological components mapped, the condition shifts from an uncontrollable event into a series of variables that can be systematically managed.